Hello and welcome back to our Cracking EMG Cases series. We're up to case 8 now. This is a case of leg pain and weakness. I hope you're enjoying my image creation here. I'm not just pulling these off the internet. I'm playing around with AI generated images and trying to balance a little more medical illustration and some clarity and aesthetics. Anyway, let's get going here. We are back to our usual method of presenting the data first and then having you think backwards to try and formulate what's going on, what's a differential, what are the clinicals. So we have lower extremity studies. And right off the bat, giving you a clue here, start out with some saphenous. I don't normally do that, and many people don't. They're technically hard to get, but there must be a reason why we would do saphenous. And then here we have superficial perineal and sural. We have some low values here. Low amplitude there, low amplitude there. Latencies are not too bad, although you could say the saphenous is kind of borderline, but I'd be pretty happy if I was even able to obtain a saphenous sensor. Sometimes you just cannot obtain them. Motor here, nothing's coming up red, but as you start picking through the data here and start looking at amplitudes, some are low. Perineal to the TA, tibialis anterior, that's also one that we don't usually do. So hopefully the wheels are starting to turn. That amplitude is low, although no reduced conduction across the fibular head. Tibial over here, we have a pretty good amplitude of tibial, but pretty low amplitude there, and a comparatively lower amplitude there of perineal. So 8.5 versus 3.8. And conduction velocities are grossly within normal limits. And again, some late responses here, F waves and H reflex. We have some positive findings, but if you are already starting to identify a trend, or if you're pausing it and looking at the numbers individually, we are going to start to see a pattern evolving here. So what is going on in this case? What are we looking for? If you were thinking of the case of the nerve conduction to tibialis anterior as well as EDB, then yeah, of course, we're thinking about foot drop. Maybe this is a case of foot drop. Since we did the perineal to the TA. Is this S1 radiculopathy? If you looked at that H reflex on the right, it is worse than the left. Positive findings on the right compared to the left. We like that asymmetry when we're calling an S1 based on H reflex. What about polyradic of L5 and S1? Sure, that could be the case in this situation. When you have S1 reflex, that is abnormal on the right, that could be S1, and a low amplitude perineal, that would be L5. These are findings that we see all the time in patients of L5 and S1 radiculopathies. In terms of the saphenous, it's pretty much symmetric and obtainable. I was happy with that. The right superficial perineal and the right sural were abnormal, but the left were normal. Perineal and tibial, you would say, are grossly symmetric, but I would say the perineals are shifting or trending into a lower amplitude relative to the tibials. So perineals are not looking as good as tibials in this situation. But no reduced conduction across the fibular head, especially for that perineal to the TA. Late responses were abnormal, but again, if you looked at those numbers, it's all right-sided. This is not bilateral, right? So what are we thinking about? What can we rule out? Well, now peripheral neuropathy, that does not seem likely because it should be symmetric, of course. What if it's a plexopathy? Did anyone think of that? Why was I doing saphenous sensory? Whenever we get additional sensory values, maybe we are thinking maybe it's a case of potential plexopathy. The saphenous in this case was actually, I was very happy with these. And that actually helped to really clear up the differential diagnosis. If you're thinking of a lumbar, the saphenous should be out. If it's really only the lower lumbar or an L5 down lumbosacral plexopathy, it would have escaped. The saphenous would be normal anyway. So it's kind of a sort of case of ruling out lumbosacral plexopathy given the saphenous were obtainable. What about foot drop, right? Well, it was not, there's no decreased conduction across the fibular head, so we shouldn't really call that. And what about an L5 S1? Can we rule that out? Well, not yet. So maybe this is a boring case of just an L5 and an S1 radiculopathy. Well, it's not. So what are the clinicals of 50-year-old male? Progressive hip arthritis. You could say that is an early age, and I would say you are correct. And some people may say, "Oh, it's fine. It's just a case of FAI and bad hip. Maybe his dad had cam lesions, and well, they're just going to get a hip replacement. By the way, do you like how AI tried to uh, generate an image of what they think a hip replacement looks like? It's not bad with some nerves around it. What is going on? Well, there's a lot more going on. Unfortunately, a case of alcohol and illicit use, IV drug use. They got an infection. It was an infection it wasn't a hip replacement yet. It was just a native joint infection. And unfortunately, they had to go through quite a bit here, washout and a resection. So they basically had a girdle stone, remove the femoral head and neck because of a septic hip joint, progressed with osteomyelitis because the patient did not get care early enough and the infection just progressed. Then, unfortunately, they got MRSA and had to be on IV antibiotics for 6 weeks. And then they got another infection somewhere else in their body, in their sternum, again, MRSA, and they had to get IV antibiotics. Finally, the patient was, went clean and stopped using a lot of the drugs and alcohol. Their immune system improved and they stopped getting recurrent infections. But as a result of all these issues, their leg became shorter. If you don't have a femoral head and neck, and all you're basically left with is this bone articulating an empty acetabulum, you're going to get leg lengthening, and you're getting a lot of acetabular bone loss from just wear of kind of like the back of a cue stick in pool, just kind of jamming into the hole in the pool table. I don't know, that's a good analogy, but it's not a ball and socket joint anymore. It's just something jamming into that area, and it's just going to wear things down. So, in terms of surgical procedures, after things, well, got better after their girdle stone and they were finally clean and no more infection, it was a couple of years, by the way, they then had an IND and they had an articulating antibiotic spacer as a first stage of surgery. Unfortunately, the patient had a dislocation event of that spacer. First ED that he went to, couldn't reduce it, went to another ED. It's just problems after problems. So that prolonged things even further for another, I don't think, three months or so. And then finally, they had a total hip done, and they had been in a wheelchair for over a year. And actually, I should scratch that. In total, it had been about 3 years since the patient was actually in a subacute. They were in a sniff, and they had chronic weakness in their leg, and they basically just were non-ambulatory for quite a long time. And once they finally got up and they were able to fully weight bear and walk and they were cleared and no infection, everything was great, their leg wouldn't move. And that was a problem. So that's why they sent them for EMG. So now we plug in. We did NCS and now we have EMG. And oh boy, we got a lot of positive findings. Denervation diffusely. And if you start going down the list, tibialis anterior, okay, there's your perineal. Tibialis posterior, nope, that is tibial. So there goes our foot drop idea. Peroneus longus, also positive. Medial gastroc, more tibial, positive. Short head biceps femoris, very key muscle to test, also positive. And even going upstairs into the hip, glute max positive, glute med normal. Paraspinals, normal. So this should hopefully start ringing some bells in terms of what's going on in your differential now. Over here, there's some signs of denervation dash reinnervation, a few nascent motor units indicating some degree of recovery. Chronicity here, there's mild increased amplitude indicating there's been some collateral sprouting and some larger amplitude motor units. But really, this is no good. This is as low as 25 or even less than 25% of normal active motor units. So there's a lot of chronicity and axon loss in some of these muscles. So to summarize here, we have denervation in perineal innervated and tibial innervated muscles distally. So it's not our foot drops, not perineal neuropathy across the fibular head. That's not long head. Short head biceps femoris was also positive. So that is now localizing things above the knee. That is a key one to do when you're thinking about perineal neuropathy. It's pretty severe, pretty bad, only about 25% in some cases. Maybe some signs of recovery, which hopefully is nice news for the patient, but not so great. When you go up to the hip, gluteus medius was normal, gluteus maximus was abnormal and denervated. I don't get too many real gluteus maximus with denervation cases. Some people say it's going to heal a lot quicker and recover faster because it's a shorter distance if you're thinking about axonal length. And by the time they present to us, sometimes it's already getting denervation dash reinnervation, so they're not having active denervation, but this was truly denervated and absolutely rock solid, stable lumbar paraspinal. So what is going on? What is this a case of? This is sciatic neuropathy, proximally in the upper leg there in hip. The pattern that we often see in this case is, due to the anatomy in the superior versus inferior gluteal nerves as they exit. If you think about the piriformis and the sciatic nerve, and I have a picture of it coming up later, one is going to be positive and one is going to be negative. This is just the case of the proximal sciatic nerve. Now, how did this happen, right? Well, in a way, it's like, gosh, how did this not happen? And it probably happened, gosh, after maybe the first or second or third surgery, or just the years in the wheelchair, multiple surgeries. Here's a picture of Girdlestone. That is the, empty hip, no ball. There's a socket that's left with acetabular bone loss because it's worn down, but femoral head, femoral neck there, and just nothing there. And this leg is just riding high, a chronically shortened leg. Then got the antibiotic spacer, which is right here. Kind of looks like a total hip, but not exactly. And then finally got the real formal hip replacement surgery. When you think of all those surgeries and all that scar tissue, there's got to be some degree of scar tissue around the sciatic nerve in that hip. There were several incisions, anterior and posterior. So the hip area was just a mess with scar tissue. Could have been a procedural injury, absolutely. With multiple hip surgeries, each successive hip surgery becomes more and more difficult and complex, and a lot more pulling and bending and separating. Often something's going to happen. If you think about the leg length, if it was a chronically shortened leg and then immediately within a few hours, suddenly that leg has been lengthened by inches, that sciatic nerve gets put on stretch. And that could easily give you a sciatic neuropathy. But would that actually affect the inferior gluteal nerve? And the answer is, well, no, it shouldn't. So this is not just a case of sudden lengthening and they got a traction neuropraxia. I'm kind of in the way here, but there's the piriformis, and we have superior gluteal nerve here, inferior gluteal nerve with the sciatic nerve, which I am blocking in this picture. That's why this is going to be positive. This is going to be spared in a case of a hip issue or sciatic neuropathy right there. So that really isolates things right in that hip joint in terms of where the problem is. Interestingly enough, sciatic neuropathy, perineal tends to be affected more than distal since it has a lateral and superficial positioning compared to the tibial division, which is more protected in the hip. It is therefore more susceptible, compression, trauma from the outside. Um, the perineal nerve compared to the tibial nerve has a proximal and distal fixation, one in the sciatic region and one downstairs at the fibular head, which makes it less stretchy and more prone to injury in all these different hip positioning that they have to do for all these surgeries. So perineal tends to get injured more in cases of sciatic neuropathy. Also, two interesting things. One, perineal nerve has less of a blood supply when you look at things anatomically. The tibial nerve has a lot of multiple arterial branches, so it's got better collateral, so it's more resilient in terms of an injury. And there is less connective tissue surrounding when you look at fascicular architecture of the perineal nerve compared to the tibial nerve. It's much higher risk for getting a deformation, compression, injury. So this is why sciatic neuropathy can be confused with a foot drop and perineal neuropathy, which is actually how this case came in as a foot drop case, perineal neuropathy, check across the fibular head. And it's like, all right, this is clearly not the case. As soon as you do tibialis posterior, you can rule that out. If you did short head biceps femoris before you did tibialis posterior, that'll also rule it out since it's placing the lesion proximally. Sciatic neuropathy is much more common to be axonal than demyelinating, which was, in this case, perineal motor was lower amplitude compared to tibial. It can also be confused with an L5/S1 radic, which is why as soon as you do tibialis anterior and you see denervation in tibant, just go straight to tibialis posterior because it's also L5, but it's tibial L5. So then you know, okay, this is not a foot drop, is not perineal neuropathy. If you're worried about L5 or S1, you can check multiple L5 and S1 muscles in different locations and of course the lumbar paraspinals. The one thing that's hard with sciatic neuropathy is very difficult to discern from a plexopathy. This is the trick and difficulty with lumbar and lumbosacral plexopathy. You have to have a high index of suspicion. And in theory, somewhere down along this course, as these nerves are coming together, things could have been injured. When we typically think of a plexopathy, though, we think of hematoma from some abdominal injury and bleeding, and it's just blood is collecting in here and causing a plexopathy. I recall a case of that. It was pretty bad. But when you have bleeding and hematoma, you're going to get a lot more of the plexus, which basically means you're going to get quads in terms of the femoral and obturator nerve in classic lumbosacral plexopathy. In a sciatic neuropathy, really not going to get that. But strictly speaking, you cannot entirely isolate a sciatic neuropathy from a lumbosacral plexopathy. But if you have a plexopathy, it's going to be fairly evenly involving perineal and tibial, and also involving femoral and obturator. So this case was not a case of that. Saphenous, right, is more likely to be involved. Not perfect, but in this case, it actually was a pretty clean waveform on both sides. So that was actually pretty reassuring that this wasn't a case of plexopathy. And then we're going to end, if you are a learner and you're kind of getting exposed to the different hip replacements that are out there, or if you're going to work in an orthopedic practice, anterior hip approach is becoming much and much more common. There are pros and cons to each, but anterior is starting to become more popular. Patients report less pain, they get back into things faster, and there's a lower risk of dislocation. These are all huge and are big problems with posterior hip approach. However, if you're, well, not used to it, it's a longer operation time. There's a higher risk of nerve injury. Lateral femoral cutaneous is the classic one, but sciatic can happen. You do have to hammer that in a little bit harder, and it's not as easy to kind of get a good mechanical advantage as you are doing this. There's a higher incidence of periprosthetic fractures compared to posterior. And again, this is not as applicable as the years go by. This is 2025 during this video. Anterior approach is increasing a lot more, and just the posterior approach is phasing out. However, there are still people that do the posterior approach because it's quicker. If you have a patient that you're worried about anesthesia and length of time, maybe this is a good option here. Lower risk of periprosthetic fracture if you have an osteoporotic patient. And if you're worried about surgical site, not joint infection or just post-op infection in general, but surgical site infection, the gluteal area is, well, quote unquote, cleaner than the groin area. There's a little bit more bacteria hanging out in the groin area there, and the surgical site infection risk does go up with anterior approach. The problems, which is huge, I've seen a ton of these, dislocation shortly after surgery, a much longer and slower recovery compared to anterior approach, higher pain levels, and in terms of some studies showing a higher rate of just general post-op infections, not surgical site, just general, compared to the anterior approach. Sciatic nerve and hip replacement, when we worry about this, yes, there is a proximity warning, so to speak, of the sciatic nerve and anterior hip replacement. You just have to be careful and, position and manipulate the limb in the correct way to try and reduce this risk, but it can happen, and we do worry about that. Posterior hip, it seems less common unless you really have the hip in a heck of a lot of flexion. You would think increasing hip flexion and internal rotation, but it's really more the hip flexion brings that sciatic nerve closer to the femoral neck. So there is a concern about sciatic nerve injury and posterior approach, just like there's a concern for anterior approach, which means you just got to be careful. I don't do any of the surgery, of course, but surgeons have to be obviously aware of the risks for both anterior and posterior and take all the appropriate precautions during hip replacement. So this was a very interesting case. I wanted to present it because it has very classic findings and real good, so to speak, denervation findings that was very prominent, and I was happy to show it to one of my students here and wanted to present it here. If you've seen a case of this, please let me know. Sciatic neuropathy is not as common as the other ones, at least in our clinic, so I don't get a lot of these. If you've seen a lot, or if you have any tips, let me know. I would love to know in the comments so we can all learn from each other. Have a good one, and I'll see you in the next video.